Thanks for GE for the opportunity to present at this roadshow. I'm Dr. Daniel Berson. I'm Chief of Anesthesia at the Heart Hospital of Austin. The first slides I'm going to go over is all about lowering the curtain. What I mean by that is how 3D technology has lowered the anesthesia curtain between echocardiographer and CT surgeon. You got to remember, the CT surgeon has been living in the 3D world forever. We're just catching up now with their 2D now to 3D. And this has formed, at least at the Heart Hospital, a much more collaborative team between echocardiographer or anesthesiologist and CT surgeon. So when we go over cases, we present in 3D, and now the surgeon can see the exact pathology. And then when he's at the scrub sink, he's thinking that he knows exactly what he's going to do before he ever opens up the patient. And this improves safety, efficiency, and effectiveness, and overall transforms CT surgery today and also in the future. First case I'm going to go over is our transcatheter mitral valve case. This is a female in her 80s. She has a history of AFib, COPD, sleep apnea, and diabetes. She also suffers from severe mitral regurgitation as well as moderate to severe mitral stenosis. Her LV function is preserved, and her STS score for mitral valve replacement is 10%. Some of the pre-op planning that was involved in this case: on CTA, we showed an annular size of 626 to 690 millimeters. She also suffered from 200 degrees of mitral annular calcification. Some of the op plan: we're going to do this through a transapical approach. A 29 millimeter Sapien XT valve was going to be placed in the mitral position. And the mitral stenosis, as well as the mitral annular calcification, were going to serve as anchors for this valve replacement. Some of the pre-op TE that was done. First images I'm showing is, again, in 2D from 120 to 150, and there's obvious severe mitral regurgitation, centrally speaking. Now, using our two-click crop view that GE provides, we're from the left atrial perspective looking down upon that mitral valve in what's called the surgeon's view, where we have A1, A2, and A3, P1, P2, and P3. You can also see that there's severe mitral annular calcification running throughout the whole length of that posterior leaflet and into the anterior A3 portion of the anterior leaflet. You can also appreciate poor zonal coaptation between A2 and P2 and A3 and P3. Now, using our flexi-slice view, we can put in one screenshot our 2D as well as our 3D images. So you have your mid-commissural view, your 120 to 150 view, and the en-face view, and then again, in great image quality, our 3D view, again from our left atrial perspective, looking down upon the mitral valve in what's called the surgeon's view, where A1, 2, and 3 are at top, P1, P2, and P3. And again, the poor zonal coaptation between A2 and P2 and A3 and P3. Now we put color flow on this mitral valve, and you can see clearly there's severe central mitral regurgitation between A2 and P2. We can also appreciate an eccentric jet right there coming out of the P3 region. So you can see how important 3D technology is to fully appreciate all the pathology that is going on in this mitral valve. The next slide I'm showing is using our two-click crop view, but this time through our left ventricle looking up onto the mitral valve. So now just picture, we're looking up and everything's now reversed. So we have now going from right to left, A1, A2, and A3, and P1, P2, and P3. And right there in the center, right when the color goes, you can see that there's poor zonal coaptation between A2 and P2. The next few slides is our mitral valve modeling program that GE provides. There is a ton of information on these programs, and at the Heart Hospital, we achieve a rate of about 93% repair rate, whereas nationally speaking, it's probably about 60%. And I don't think enough people use 3D technology or these mitral valve programs to really understand exactly what's going on and to help their CT surgeon. So the first thing I'm going to look for is our AP diameter ratio to our AL/PM diameter. And ideally, what you're looking for is a 3 to 4 ratio. And that leads right into our sphericity index. So anything greater than 0.75, which is ideal, or a good saddle shape of that mitral valve, and closer to about 1, all of a sudden you have an annular distortion or geometric distortion of that annulus, more from a saddle shape to an oval shape. And then I can convey that information to my surgeon, this need of a ring or band, to reinstate the proper annular geometry, and so the overall mitral valve apparatus can function correctly. And lastly, I'll look at the non-planar angle. And think about the non-planar angle by thinking about like a Pringles potato chip. And basically on the end of each side of the potato chip is a certain amount of height. And that's your non-planar angle. And normally you're about 140 degrees or less. Anything greater than that, or up to 160, actually it becomes a saddle shape to a flatter, non-saddle shape annulus. And again, the need for a ring or band will be necessary to reinstate the proper overall geometry of that annulus so the apparatus works completely. The next tab I look at is our leaflet tab. In our leaflet tab, what I look for is to differentiate our patients who have normal leaflet pathology to somebody who suffers from fibroelastic deficiency to somebody or a patient that suffers from Barlow's disease. And what we're looking for is our tenting height and tenting volumes. Normally, your leaflets have a tenting height of 1 millimeter or less and an overall tenting volume of 1.15 cc's or less. That's normal leaflets. When you have a patient that suffers from fibroelastic deficiency or single segmental billowing or tenting, the tenting height is increased over that 1 millimeter, but the overall tenting volume, it remains under that 1.15 cc's. And then finally, somebody who suffers from Barlow's disease or multi-segmental billowing, tenting, or redundancy of those leaflets. Both the tenting height as well as the tenting volume will be increased over the 1 millimeter and 1.15 cc's respectively. Again, so I'll be able to convey all this information to my surgeon, and maybe not just a resection will be needed in that posterior leaflet, but actually adding neocores to the anterior leaflet to reinstate the proper geometry of both of those leaflets. And finally, I look at the coaptation tab. In the coaptation tab, I'm going to reference Dr. David Adams at Mount Sinai. And what he has said in papers is about the optimum zone of coaptation. And basically, what he looks for, and he does this through an ink test. And his ink test is performed while on pump in this flat, non-dynamic heart. And he draws a line, and anything amount of leaflet that's underneath the annulus, he looks for about 4 millimeters to 10 millimeters amount of leaflet below the annulus. And he thinks that if you achieve that, that you get a long-term durability of that mitral valve. A lot of times the mitral valve is repaired, looks fantastic, coming off pump, there's no color flow, and then 6 months, a year, you're back with 2+ MR. And he believes that this optimum zone of coaptation, or 4 millimeters to 10 millimeters, are the reason why we're not getting good enough durability of that mitral repair. And what I look for is our anterior closure line length in 3D and our posterior closure line length in 3D. And what I look for is that those two numbers are very similar. If you have a big discrepancy, or greater than the 4 to 10 millimeters, then I'm able to also convey that that mitral valve repair probably won't last to the surgeon, and that we'll need a better repair rate, or something else has to be done before we leave the OR. So going back to our transcatheter case, we performed through a mini left thoracotomy, and there was a transapical access into the left ventricle. A large 26 sheath over a stiff wire was placed through the central portion of the mitral annular calcification and valve. A 29 XT sapien valve was loaded in advance, and the thinking is that we're going to land 20% of the cage into the left atrium, and 80% of the cage was going to be left in the left ventricle. So here on our 2-click crop, again, from our left atrial perspective, looking down upon that mitral valve in the surgeon's view, you can clearly see that the catheter is placed dead center between A2 and P2. You can see how vital 3D technology is in guiding the surgical team of the placement of this catheter. Next, I'm going to show GE has also provided this triplane. And this triplane is fantastic for your cardiac team. Basically, it'll show you in one screenshot the 120 to 150 view, the mid-commissural view, as well as the four-chamber view. In all three planes, you're able to see that the catheter is placed dead center of that valve. And then with confidence, your cardiac team can then deploy that valve. So we rapid paced. The valve was deployed with steady inflation. And then we're going to check for valve function, any paravalvular leaks, and also any LVOT obstruction. So here, the sheath is still engaged within the mitral apparatus. And you can see that there's some mitral regurgitation. But everything is within the cage. There's no obvious paravalvular leaks. And once the sheath is removed, you can see that mitral valve working fantastically. There's no obvious paravalvular leaks, and just trivial central MR. And then finally, in 3D, coming from the left atrial perspective, again, looking down upon that mitral valve, you see this gorgeous tri-leaflet mitral valve with no obvious rocking or dehiscence. So we're very, very excited about these pictures and how well they came out. And finally, in our flexi slice, again, you can see in 2D as well as 3D, this perfectly placed mitral valve tri-leaflet with no obvious rocking or dehiscence. And then lastly, again with our two-click crop view, this time not from the left atrial perspective, but from the left ventricle looking up, you can see that the valve is functioning. But most important, I'm showing that that LVOT, or the outflow tract, is not being obstructed. So hence, a very successful transapical mitral valve replacement was performed. And with the really heavily relied on our 3D technology to take us through the entire case. Thank you very much. And any questions? So what we do is it's through a left mini thoracotomy position. They open up a little bit so they can see. And actually, before we even make incision, the sonographer comes in and actually points exactly where the entrance point should be. So we have them, and then they give it to the surgeon. He plays around for a little bit, but it's always the sonographer that can get it perfectly down. And then he goes through there, and then when he's puncturing, then we'll put a big catheter. But when when we close up the heart, that's when we actually instate rapid pacing. And so all of a sudden we'll rapid pace, the blood flow will be down to about nothing, and then we take out the big cannulas, and then we'll suture back up in a purse string. And so that's how we do it through that. And it's amazing because really the advent of like TAVRs, everything is, a lot of them is going through transfemoral. You can do transaortic, but you can also do transapical. And the thinking is the more they've been pushing transapical, because not only that the aortic valve is right there, that mitral valve is right there. And so in this case, we actually took the knowledge that we had in our TAVR program and utilized it to place a mitral valve. It's actually only about 30 of those cases that have ever been done in this country. And we were one of the 30, and they flew in somebody from Italy to Proctor, and they were like, unbelievable, because there was no ring involved, there's nothing else. There was just the mitral annular calcification and mitral stenosis that was going to serve as that anchor. And so far, so good. So we'll see.
Residual apical hypokinesis or anything from the puncture?
No, it's a small incision, and we haven't seen anything from that. It's pretty incredible that they can go through, but it's the blood. Once we take out the big catheter, the cannula, we all got a little nervous, but once we rapid pace, the purse string, we don't even lose any blood. So it's fantastic.
That's pretty incredible. Any questions from anybody? Don't be shy.
Did you guys get any of that, that mitral valve program? That's also something that I think it's not even being utilized at all throughout the nation. And I think people just don't understand all the numbers that can be done, and then how you can now have a plan and tell your surgeon exactly how the procedure should be. It's amazing the collaboration between CT surgeon and echocardiographer or anesthesiologist in the 3D world. And always remember, that 3D world, he's always been living there. We're just catching up, and now that we're together, it's an unbelievable collaboration between the two. And it really has just transformed mitral valve surgery, but also, as you can see, percutaneous surgery. We're just guiding the entire thing. They're not even really using fluoro that much anymore. We're just guiding it all through the 3D TE. So they rely very heavily on that. There's a big future in 3D. So we're really excited. And thanks again to GE for letting me present.